Good day to you all. Bonjour tout le monde. I am Jeff Nankervel, President and CEO of the Asia Pacific Foundation of Canada. It's my pleasure to welcome you on behalf of the Foundation to our event today, the webinar on our releasing our work entitled Pandemic X, Are We Ready for the Next Time? Translating Asia Pacific COVID-19 Experiences into resilient and comprehensive responses to future pandemics. First of all, let me say that the places Canadians call home are the traditional territories of many First Nations, Métis, and Inuit. APF Canada's own headquarters, where I speak to you from today, are on the traditional, ancestral, and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh peoples. We're grateful to Canada's Indigenous peoples for their stewardship, and we are collectively committed to the process of reconciliation. Now, just to set the scene for our discussion today, it was just over 2 years ago that APF Canada started tracking Asia's policy responses to COVID-19. Asia was experiencing the initial wave of the pandemic a few months ahead of Canada, and there was a lot that we could learn. And then more recently, this work transitioned into translating Asia-Pacific experiences of COVID-19 into strategies and responses for future pandemics for Canada. Now, along with our guest experts, Professor Peter Berman from UBC School of Population and Public Health, and Dr. Kelly Lee from Simon Fraser University's Faculty of Health Sciences, we're pleased to share with you our findings today. And before we get on to the substantive program, just a couple of brief housekeeping notes. This webinar is being recorded, and the recording will be available on the website in the coming days. We welcome and invite audience questions. Please submit them through the Q&A box that you should see at the bottom of your screen. And this session is hosted in English, but we welcome questions in both English and French. En ce qui concerne les supports techniques, for technical support, please reach out to Mandy Ng at events@asiapacific.ca. Alors, ça me fait grand honneur maintenant de passer la parole à Jeff Reeves. It's my pleasure now to hand over the virtual microphone to APF Canada's Vice President for Research and Strategy, Jeff Reeves. Take it away, Jeff.
Thank you, Jeff. I'm Jeff Reeves, the Vice President for Research and Strategy at the Asia Pacific Foundation of Canada. So it's my pleasure to help launch today's event and to draw attention to some of the work that the Foundation has been doing around the pandemic with a focus on the Asia Pacific. Just to give a little bit of a kind of a context to how we started this research about 2 years ago, and it's amazing that it's been 2 years. We found ourselves as a foundation looking at the Asia Pacific and trying to understand what was happening around the region with respect to the pandemic. As a foundation that has a mandate to try to translate events that are happening in the Asia Pacific back into the Canadian context, what we decided we could do in order to help Canada's own national approach in response to the pandemic was to look at what Asian economies and Asian states were doing. In particular, seeing that many of them were 2 to 3 months ahead with respect to the pandemic outbreak and had more established pandemic response plans in place than Canada seemed to at that moment in time. So we took on that mandate ourselves to look at broad policy that was taking place in economies like South Korea, Japan, and Singapore. Our initial attempts were put together in story maps that attempted to outline some of the policies that we saw around, for example, contact tracing, the use of technology and identifying infected individuals, testing, school policies, and we put those together, and those resources are still available on our website for those that are interested in going back and looking. After we took that initial kind of foray into trying to translate what Asia was doing around the pandemic, we put together a much more robust proposal that we took to the Public Health Agency of Canada. and put forward a proposal to try to do a broader, deeper dive around what was happening in the Asia Pacific with relevance to Canada's own experience. And in partnership with PHAC, the Public Health Agency of Canada, we agreed to draft a number of papers focused on different aspects of the responses that we saw across the Asia Pacific. The first being on public health policies related to pandemic response, the second being on digital innovations around the public health space, the third being around the trade and flow of medical supplies between Canada and the Asia Pacific, and the fourth around pandemic engagement, response, and discourse within regional dialogue mechanisms. And all of four of those papers are now up on our website, and you can access them at asiapacific.ca. Now, notably, as we started this research about a year ago, a lot of our analysis is focused on the early phases of the pandemic response. We're in a much different situation now. However, we find that much of the analysis that we did about the early stages of this response is now more applicable than it was before, as we're trying to think about how to approach the current phase and position ourselves to be more resilient in the face of future pandemics, whether with respect to a continued COVID epidemic and pandemic, or with a new presentation of a novel virus in the future. So we have a great agenda for you today. As Jeff already mentioned, we have Dr. Peter Bergman, a professor at the School of Population and Public Health, University of British Columbia, who will speak initially on why pre-pandemic assessments failed to accurately predict pandemic responses in the early phases of the COVID pandemic. Professor Bergman is a health economist with over 40 years experience. He's previously worked at the World Bank and is currently a professor of the School of Population and Public Health at the University of British Columbia, and an adjunct professor in global health at Harvard's Public Health the T.H. Chan School of Public Health at Harvard. He's also an adjunct professor at the Public Health Foundation of India in New Delhi and is an advisor to the China National Health Development Research Center. We will have, following Dr. Berman's presentation, two of our own staff, Candice Ruck and Daniela Rodriguez, both project managers for our work on the pandemic response, who will be introducing some of the findings that we had from our research. And then finally, we'll be introducing Professor Kelly Lee, the Research Chair, Tier 1, and Professor of Health Sciences at Simon Fraser University, who will speak on how lessons from COVID-19 can help us inform and prepare for future pandemics. Dr. Lee's specialty is international relations, and she has extensive experience in global health. She co-established the WHO Collaborating Center on Global Change in Health and chaired the WHO Resource Group on Globalization, Trade, and Health. She's currently the Associate Dean of Research and the Director of Global Health at Simon Fraser University. Her current work includes leading the international pandemics and border projects. After our speakers are done, we'll open up to a Q&A session at the end, and I encourage all of you to put your questions in the question and answer box or the chat functions during the discussion so that we can facilitate that process at the end. So over to you, Peter, to get on with the deeper dive into some of the findings that we've had around our research. Thank you.
Great. Thanks, Jeff, for that kind introduction. It's my privilege to speak to you today from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples near the UBC campus. I want to also express my thanks to the Asia Pacific Foundation for the opportunity to help open this conversation, and also to the Public Health Agency of Canada for its foresight in seeking to learn from Canada's Asian neighbors. So we're 2 years into the pandemic and it's still evolving. It's not the same pandemic it was 2 years ago, and we're still not 100% sure where it's going. And in these 2 years, almost all the jurisdictions globally have encountered a fairly similar challenge of a novel, highly transmissible, serious infectious disease with serious consequences for individuals' health and clearly serious consequences for society and economy. What they encountered, these different jurisdictions around the world, from an epidemiological and a biomedical perspective, had much more in common with each other than the differences between them. There were some differences, but it was quite an unusual, global, fairly common threat. But what they experienced as a result of this threat, which was a consequence of both their preparedness as well as their response, and it was not only what they encountered, but it was these other factors that mattered in terms of what they experienced. And these resulted in very different results and experiences around the globe. So much of the analysis that we've done of these experiences has indicated that they're not simply the result of what we might call the more technical factors around preparedness. Certainly the larger environmental factors like national income, wealth, or education, form of government, did not serve to be very predictive of what actually transpired in different jurisdictions. And widely cited, ironically, in 2019, a group of highly regarded international organizations and experts evaluated the technical preparedness of almost all countries around the planet in something called the Global Health Security Index. And in this index, countries around the planet were ranked in terms of their preparedness for a crisis like COVID-19. And ironically, this ranking had little association with what countries actually experienced from this encounter with COVID-19. The US and the UK were ranked numbers 1 and 2 around the world, and China and Vietnam were ranked number 50 and 51. And we can see very different examples of what they encountered and experienced from the actual pandemic. So it isn't fair to say entirely that many countries were not prepared. From what we thought of as what seemed to be technical aspects of preparedness, a number of countries were reasonably prepared, as best could be assessed in advance of the pandemic. And these technical factors, public health structures, expertise, preparedness in terms of physical capacities and so on, they mattered, but so did many other things. Things like politics and the interface between political structures and the technical and scientific structures in different countries. The role of government and non-government organizations, both within countries and also globally. Decision-making processes between public health agencies, experts, and political and other social structures that resulted in action. And communications with the public mattered a great deal in terms of helping to support public knowledge and compliance with the practices that were intended to be adopted. So the Asia Pacific Foundation's review of these Asian experiences in the early parts of the pandemic draws our attention to these types of factors in addition to the more technical aspects. And I think that's a very positive element of the work they have done, and helps to distinguish and explain the contribution of these different factors. The Public Health Agency of Canada has raised these issues for Canada itself in light of its recent 2022 report on the state of public health in Canada. And now is the time to look at these experiences around the world and learn the lessons from them, both for future pandemic diseases and other epidemic diseases, as well as other population health threats, which may not only be infectious diseases, but may come from other causes. So I hope we're going to have a very interesting session, and I look forward to learning more about their findings along with you. And thanks, Jeff, over back to you.
Great. Thank you so much, Peter, for that. That was really great setup for what we're going to get to discussing now. Excuse me. So Daniela and I, who, as Jeff mentioned previously, were project leaders on this overall research project, we're now going to talk about their reports on public health and digital technology. Next slide, please. Thanks. So we'll begin by briefly discussing the scope of the overall project, And then we're going to go over some of the key findings from our analyses. Next slide. Thanks. So in terms of the scope, sorry, next slide, Mandy. Thanks. So in terms of the scope, we mainly focused our analysis on countries that controlled the virus really well and maintained really low case numbers and mortality. You can see from these graphs, on the left is cumulative cases through to June 2021, and on the right is daily mortality figures through to the end of 2020. And you can see that both cases and mortality were quite low in the Asia Pacific countries that we've selected for our analysis. We also focused mainly on countries that practice democratic forms of governance, and that was simply to make our findings more readily applicable to the Canadian context. And finally, in terms of the timeline that we selected for our analysis, we have confined most of our research to 2020, the first year of the pandemic, with particular attention paid to the very earliest responses in the first months of 2020. So just to set up the context for that analysis is, at the time, the original strain of the virus was the predominant strain. And it was novel at the time. The characteristics of the virus were still being revealed even as the response was unfolding, which added to the challenges. As well, there were minimal therapeutics available and no vaccines. So it's a very different context from what we find ourselves in now, more than 2 years later. But the real relevance is to sort of set up our future pandemic preparedness so that we can respond better if we're again in the future faced with a novel and unknown virus. Next slide, please. Thanks. So now to move on to some of our key findings. We go back to the very beginning of the pandemic. Our analysis really showed that the timing of the response was a key component to preventing transmission in that first phase and defining the effectiveness of the overall response. And in terms of viral spread, a matter of weeks, we're able to make a big difference in the extent to which COVID-19 could be transmitted, and thus in how easily it could be contained. Excuse me. So this timeline here, it shows just a few key snapshot moments from the first few months of the pandemic. And it illustrates how the countries that acted fastest also correspond to the countries that had really low case counts and mortality from the previous slide. You see that Taiwan and Singapore had begun to take measures in January, even before the WHO declared that COVID-19 was a public health emergency of international concern, which they did at the end of January 2020. In contrast, most countries outside of Asia didn't begin to take real measures until around mid-March. And that was corresponded to the point where the WHO declared that COVID-19 constituted a pandemic. So big difference there between Asia's sense of urgency compared to much of the rest of the world. Next slide. So the benefits of an early response can also be seen if you compare the stringency indices of various responses. And the stringency index simply incorporates all levels of restrictions into a single metric. And as you can see in this graph, the countries that displayed a more aggressive response throughout the first few months of 2020, actually, if you follow the response through to the corresponding period in 2021, had less stringent overall responses compared to countries that initially delayed their restrictions. And our findings showed that this early response tended to facilitate less stringent responses overall, just because the virus was more contained at the population level. Whereas if it was given time to establish significant community transmission, then more aggressive measures over longer periods of time were ultimately required to regain some level of control over it. Next slide. Thank you. So this more rapid response that we see from many of the countries that we analyzed was really due to sort of a heightened risk awareness. And that was sort of the result of a combination of factors. One of them was certainly their proximity to the epicenter of the pandemic in Wuhan, China. And this meant that they had an awareness that they were going to be among the first that COVID would spread to. But our analysis also showed that extensive experience with past outbreaks also contributed to their sort of heightened risk awareness. So they had previous experience with outbreaks of novel pathogens, most notably SARS in 2003 and MERS in 2015, as well as other additional smaller outbreaks. And these experiences had really informed several key areas of their pandemic preparedness. including legal, financial, institutional, and technological reforms that were either implemented or else strengthened after experience with previous outbreaks. And collectively, a lot of these reforms really contributed to their impressive response to COVID-19. We also found that their previous experiences benefited their responsiveness in practical ways, including an emphasis on drills and exercises to actually practice their pandemic plans. Many of these countries, including South Korea, Singapore, and Taiwan, all emphasized improving their pandemic preparedness through the benefit of practical experience. And our analysis showed that these exercises really helped to shape the efficiency and the coordination of their response to COVID-19. Next slide. So another area where previous outbreak experience really provided the most notable benefits was in the area of their national public health institutions, such as Taiwan's Centers for Disease Control and South Korea's Disease Control and Prevention Agency. In their response to previous outbreaks, both Taiwan and South Korea had identified that coordination across levels of government and between ministries of government was an area that really needed improvement. So following those outbreaks, both countries instituted significant reforms to their public health institutions. And those reforms included structural and legal changes that gave the agencies more authority to coordinate their pandemic responses. They also included institution level changes to their organizational structure and staffing. And all of these combined to really improve their ability to coordinate and execute a more cohesive response to COVID-19. Next slide, please. So another area that benefited from past experience was just capacity. The ability to rapidly scale up capacity to meet the demands of a pandemic was something that many of the countries we analyzed had in common. Most countries around the world have had issues with capacity, and it's limited their responses in everything from testing, contact tracing, to PPE supplies, to their healthcare capacity to treat sick patients. It's been a real challenge, basically globally. But our research showed that capacity building was an area that a lot of Asia Pacific countries had previously experienced struggles with and had sought to improve after past outbreak experiences. So the reforms that they implemented covered a wide variety of areas, but really included increased investments in public health, increases in their training and staffing, the use of digital technologies to reduce the burden on human capacity, and the development of public-private partnerships. And so just this slide here shows an example where testing is an area that can really benefit from the ability to quickly increase capacity. So early expansion of testing contributed to a successful pandemic response because countries that rapidly increased their testing capacity were better able to control the overall spread of the virus, and this allowed them to maintain lower case counts and mortality. So you can see on this graph that the tests per case identified in the early months of the pandemic, several of the countries that had the lowest morbidity and mortality from the previous slide demonstrated rapid increases in their testing early on. And this was a key component of what allowed them to establish that early control over the pandemic. Next slide, please. Thank you. So our research also showed that countries whose pandemic response was strongly guided by their experts and therefore very much science-driven tended to have pandemic responses that were more effective overall. And a couple of examples, one is Taiwan. They were in a really fortunate position early on because they had Chen Xiaoyan, who was an epidemiologist by training, as their vice president at the time that COVID arrived. More importantly, Dr. Chen was also Minister of Health during SARS. So Taiwan was able to incorporate significant institutional memory into their response. And that was a really vital component for them. New Zealand is another interesting example in a very different situation. They actually did not have a national public health institute at the onset of SARS, or at the onset of COVID-19, sorry. However, they did model their responses very much on the advice of their pandemic advisory group, including scientists such as Michael Baker, who's pictured here. And that really shaped the effectiveness of their response. Next slide, please. Thanks. So that sort of science-driven approach is really illustrated if we look at the strategies the countries used in their pandemic responses. So before COVID-19, most countries' pandemic plans were based on a mitigation model, which focuses on reducing transmission to protect healthcare capacity. Practically, that's the flatten the curve model that most of us are familiar with. However, when COVID-19 arrived, some countries were more able to adapt to the specific characteristics of this pathogen. And really neat examples of that include Australia and New Zealand. Both those countries initially mounted mitigation strategies based on their pre-existing pandemic plans, but they then pivoted to an elimination strategy after observing that China and Taiwan, who were a couple of months ahead of them on the curve, were successful with that approach. So if you look at this graph, you can see that countries that adopted elimination strategies, including South Korea, Taiwan, and Singapore, ultimately not only had far lower case counts and mortality, but also experienced less overall economic decline than countries that remained focused on a mitigation strategy. So we can see that a strategy that really fits the pathogen can both protect the population and the economy more effectively than a more ill-fitting strategy can. However, that's not to say that an elimination approach is appropriate for every pathogen. As we can see now with the Omicron strain, our analysis isn't arguing for one specific strategy over another. Well, the relevant point that we were trying to make is that a pandemic response plan that is flexible and adaptable to the characteristics of the novel pathogen, as well as to learning from the experience of others that are further ahead on the curve, can really result in a more effective overall response. And I'm now going to pass off to Daniela to talk about some of the findings of the digital technology analysis. Thank you.
Thanks, Candace. Yeah, so in multiple Asian economies, technology has not been a standalone solution, but has aided significantly in capacity building, as Candace mentioned previously. This has been particularly around contact tracing, the surveillance, which refers to quarantine monitoring and enforcement. Third, the distribution of medical supplies, and telemedicine, which is basically remote or virtual doctor consultations. So there are multiple examples, like there's not a single model that several Asia-Pacific economies used for any of these technologies. Solutions like the integrated contact tracing databases employed in both South Korea and Taiwan were very effective in significantly reducing contact tracing times. For instance, South Korea's smart quarantine system is credited with reducing the times to identify close contacts and confirmed from a confirmed case from 24 hours to just 10 minutes. This greatly enabled the quick isolation, testing, and treatment of the necessary individuals, and aided in a quick response. In terms of medical supply distribution in Taiwan, the mask rationing plan 1.0 provided a real-time mask availability map, originally started by civilians, or like technically savvy civilians and civil society members who wanted to aid in responding to the pandemic. The map was populated from crowdsourced information provided by users, and it allowed people to have a real-time mask availability map. The platform allowed to see inventories nearby to a person, so they knew where to easily purchase and pick up masks. Later, the system allowed for online purchases and in-store pickups. This significantly reduced panic buying and provided data to the health authorities for further planning and management of PPE stocks and distribution. However, it is important to recognize that digital technologies, no matter their purpose, were only effective in lessening COVID-19 impacts as part of a more holistic pandemic preparedness and response plan. They require the backing of other measures and response capacities. Digital contact tracing that proved effective, such as that seen in South Korea, Taiwan, Singapore, was mostly effective due to the ability of the countries to actually act on the information the digital solutions provided. In this case, identifying individuals or clusters early on that required testing, quarantining, and treatment, hence contributing to the curbing of community spread. Next slide, please. So governments with effective digital tools and had pre-pandemic technical, legal, and public health infrastructures, which provided a critical foundation for digital tools to be developed and employed with positive results. Technical capacity speaks to existing interoperable and secure digitalized government services, as seen on the UN e-Government Development Index, which evaluates government capacity to provide online services as a key pillar. So in this index, Asia as a region scores second, and they have multiple trailblazers actually shown on the graph, which are South Korea, Singapore, and Japan. Secondly, governments examined in our report also counted with key legal and institutional infrastructure, and clearly delineated standards and protocols for, one, empowering key agencies, like Taiwan CDC, to develop digital tools that facilitated their pandemic response operations and duties, and second, securely access and share personal data for public health purposes. So the existing specialized institutions like the Korea Disease Control and Prevention Agency were also accountable stewards and for the aggregated data collected and processed for the pandemic response. Okay, next slide, please. Okay, now moving on to a little bit of a less technical, but yet very important pandemic response measure is effective communication. This involves keeping the public informed on health risk, state of the outbreaks, to encourage compliance and back up sort of the rationale behind any measure. This goes from mask wearing to using digital contact tracing applications. Although past experience from outbreaks has certainly played a role, the level of cooperation with restrictions and public health measures have also been at least partly attributable to transparent, fact-based communication that is consistent among multiple levels of government and across the national territory. This impacts, like I mentioned, both traditional public health measures in the event of an outbreak, as well as the new, more technology-based measures. So fact-based, consistent communication really goes a long way into building trust, particularly with the public and other key stakeholders, which is my next point. Next slide, please. Okay, so much of the discussion around the use of digital technologies in pandemic response has centered on the risks and dangers of, privacy intrusions and debates on balancing individual privacy with the public good. As this graphic shows, privacy concerns among the public are strong across both sides of the Pacific. In our examined countries, pushback from the public and civil society to government use of digital contact tracing and quarantine enforcement really focused on advocating for better accountability and transparency on the collection, use, protection, and retention of data used in the pandemic. Specific governments have had to enhance their transparency on public health measures, the public health purposes of the data of data collection and the use of digital tools. And in some instances, they've had to change data disclosure protocols to still keep the public informed, but without leaking information that could de-anonymize individuals or communities to their own detriment. This is particularly for minority groups that might not want to be associated with particular outbreaks for fear of persecution or stigma. This is a lesson of experience for this particular pandemic. Further, robust and transparent data protection laws have also contributed to trust building in places like South Korea, especially trust building towards the use of technology and pandemic response. Next slide, please. Our research has also showed that familiarity with mobile applications in daily life, access to government services online, and sort of the general opinion on emerging technologies like artificial intelligence and big data, as seen in the graph right now, have contributed to the tolerance and adoption of digital tools in a health crisis. We also live in an era when societies are increasingly technically knowledgeable, which means that mechanisms for civic collaboration, engagement, and incorporation of feedback. So this goes either through supporting grassroots tech initiatives, such as the mask mapping project that emerged in Taiwan, or releasing source code from open source digital applications, as seen in Singapore, are key to building trust. Next slide, please. Yeah, so now nearing the end of our presentation of our key findings, this is more of a summary of our findings and analysis for both the project reports on public health and digital innovation and pandemic responses. You can find further analysis and recommendations on these two topics in our full reports. You can also find reports including findings, analysis, and recommendations on two other really interesting and well-researched topics that our project covered, which were, as I introduced before, supply chain disruptions and international engagement for global health. And these are all available at the APF website. So next slide, please. Also, so to conclude, given the importance of past experience that emerged from our analysis, this is Canada's first really rough pandemic experience. So now it's Canada's real time to learn, adapt, and prepare for the potential of future pandemics, similar to how Asia-Pacific economies did after facing SARS or MERS. Also, Canada needs a holistic approach to pandemic preparedness and response that goes beyond the public health realm, for instance, into the data governance aspects that we have touched on. Lastly, it is key that Canada really expand horizons for lessons learned that can contribute to a more pan-Canadian responses to a future health crisis. And this involves going beyond our own borders or close neighbors to look for lessons. Now, I would like to introduce our second guest speaker for today, Dr. Kelly Lee. She is a professor of health sciences at the Simon Fraser University. Dr. Lee is also the Canada Research Chair in Global Health Governance. Her work studies transboundary health risks, both assessing the capacity of current institutions and identifying methods to address governance gaps for future pandemic preparedness. So yeah, over to you, Kelly.
Thank you, Daniela and Candice, for that presentation. Thanks to the Asia Pacific Foundation for the invitation to add to this important discussion. I'm privileged to be joining you from North Burnaby, which sits on the unceded traditional territories of the Coast Salish peoples. And I really want to congratulate you both for a tremendous job just reviewing and summarizing such a daunting amount of data and evidence arising from just that first year of the pandemic. It's been really interesting to read, and you've created very readable reports that we can learn from. And we need more of those sorts of efforts if we're going to do better next time. I've been given this task, quite a daunting task, of trying to draw some lessons, and they're going to be very selective. You've covered quite a lot of ground already, but things that we can take forward for future pandemic preparedness. And I think this is going to be an ongoing research task, also a subject of much discussion among researchers, the public health community, government officials, private sector, and individual citizens. And I think that's very important. So there's going to be a long list of lessons, I think, coming out of those discussions. I can really only touch on a few. It's just before I get to those, it's important to note at the start, I think, that as we seek to draw lessons, that no country has done everything right all the time during this long pandemic and ongoing pandemic. Countries that have done well at one point in the pandemic have not necessarily done well throughout. And we already seen that now. There's been ups and downs throughout. So we might learn lessons from key points of action or key points in time. Countries have also maybe done well in some aspects, such as mask wearing or having effective lockdowns, but they may not have done so well in other aspects, such as vaccination. So that's important to note. And finally, I would preface my remarks by saying that how we measure effectiveness will vary depending on each society's goals and values and beliefs. And this will influence who we have protected during this pandemic and who we haven't. It's really important when we determine how successful we've been, it's how we define success. That's really a really important aspect. So comparative analyses can be very challenging given all those prefacing remarks. But let's assume that it's number of infections, total number of infections, and deaths per capita. We're just talking about the very blunt end, the public health outcomes. How can we draw lessons for at least minimizing or limiting those aspects? And I think Professor Berman's comments, Peter's comments about the appropriateness of pandemic preparedness indices was a good starting point, because it looked like we weren't really measuring the right things to be prepared, and we need to reflect on that. So I'm going to talk about 3 lessons as quickly as I can, because I know we have limited time. 3 broader lessons to try and pull together some of the things that were talked about in the reports. The first lesson, I think, is that pandemics are not simply events that happen somewhere out there. And by definition, of course, they are disease events that have truly global reach and global impact. Geography has perhaps insulated us to some extent in Canada from recognizing this, at least fully. It's true that, most recent pandemics have started in either Asia or Africa, and this is due to a number of reasons I won't go into, but there's a sense that somehow pandemics are out there and they're going to stay out there. And so we have not really been impacted previously with pandemics, at least to the extent that we haven't been impacted enough. And that might be the reason, and the discussion around Asia Pacific countries having this history was very much a factor. So as Candace already described, these countries learned from these outbreaks, put them on a good footing when the COVID-19 pandemic came along. So, South Korea, Taiwan, Vietnam, all made changes to their public health systems, very fundamental structural changes that really made them more prepared and on the alert. We, of course, had SARS-1. We did make some changes. How sustained were those changes? How much did we continue to have those structural changes supported effectively, resourced in terms of people and in terms of funding? That is a big question. So I think despite being a highly globalized, perhaps one of the most globalized countries in the world in terms of population mobility, trade and investment, cultural influences, I don't think Canada has quite recognized that global health is local health. We have a dominant framing still in this country of global health being health in the developing world. And if you look at funding and research and projects and so on, global health is still largely an act of charity. And so this framing may explain why we did not act with a sense of urgency, that we had this wait and see attitude because pandemics are about something that happens to other countries. So I think that would be one lesson I would take away from that first year. The second is that there's a saying that if you've seen one pandemic, you've seen one pandemic. I don't know if you've heard this saying, but it's been going around, and it's really important because, of course, each pandemic is different and distinct in terms of the pathogen, the context, and thus the outbreak dynamics. So prior to COVID-19, and since 1988, we've had pandemic preparedness plans in Canada and within many of the provinces. However, while they've been updated and reviewed over time, these plans tend to focus on pandemic influenza. And this is going to be a big event, there's no doubt. And I think that's the one that has been feared for many, many decades. And the H5N1 outbreaks, the H1N1 pandemic kind of reinforced that concern. So you might think, okay, this is good. We have plans in place for pandemic influenza, which is a real risk. But so assume we have plans for other pathogens that might cause a serious pandemic. And unfortunately, many countries, including Canada, didn't really have those plans in place. So we were essentially, our pandemic preparedness plans were essentially pandemic influenza preparedness plans. So in East Asia, it's, we've already heard there are many different outbreaks that have occurred, many epidemics. And so WHO has tried to move countries towards what's called an all hazards emergency risk management for health approach. And that essentially means that we have to strengthen capacities to manage the health risks from all hazards, not just a particular virus or a particular type of pathogen, but for any public health emergency that might come along. So really having that nimbleness, that flexibility, that abilities to adapt is really important. And I don't think we had that. And then the third lesson I would mention in these remarks is the role of social cohesion. And this was already mentioned to some extent. So COVID began as a public health emergency, but its reach and its duration meant it soon became a whole of society emergency. Simultaneously a health, social, economic, and political crises across this world, this globe. And indeed, I would describe it as a whole of planet emergency. There's, no one in the whole world who has not been impacted by this pandemic in some way. But during the first year of this pandemic, those countries that were then able to recognize this and come together quickly across government departments, across different parts of society, those are the countries that fared better than those that tended to fragment or had governments that didn't work together and were very divided rather than united in their response. So social cohesion refers essentially to those strength of relationships that we have in a society, a sense of solidarity among members of a community. And solidarity is basically an awareness among members of any society that we have shared interests, we have shared objectives, and we have shared values or standards. And solidarity creates a sense of unity among individuals and among social groups, and feelings of these stronger bonds within and across different groups that foster this trust that was already mentioned, trust in each other, but also trust in our government institutions. We're currently witnessing what social cohesion can achieve with the invasion of the Ukraine, for example, and the response of the Ukrainian people. So this is a great example of how social cohesion is so important to society. So during COVID-19, as I say, we seem to have variable levels of social cohesion. And this is a really key factor in how we've responded. So in Canada, I should say in Taiwan, Japan, South Korea, you can find lots of examples where the measures that were rolled out were done in a way that reinforced social cohesion rather than undermine it. And I think that's something that in Canada we need to reflect on. But I also would say that just finally that in Canada, the pandemic has really tested our cohesiveness as a large country built on diversity. Our political structures and our processes with our federal and provincial governments, really reflect the diversity, and we need those structures but undoubtedly we've had to work harder than some of the Asia Pacific countries to create and maintain social cohesion as a result. So during the first year, I think we did relatively well overall, with Canadians really pivoting sharply, complying with public health orders overall in a very cohesive fashion. And we heard that phrase over and over, we're all in this together, and we were, and we are. But as time has passed, I think we've seen cracks in that cohesion. And it turns out that the pandemic has had very inequitable impacts on people across the country and across the world. Countries then that recognize those inequities and mitigated them probably maintain social cohesion, and those that perhaps didn't do so well at addressing inequities saw cohesion perhaps become unraveled. So there's a clear lesson there. We need to strengthen those relationships, bring ourselves together back as Canadians to build back better. And that's going to be, I think, a major challenge. And so in summary, and I know we're running out of time, but I would just say those three lessons for me, global as local health, the need for an all hazards approach, and the importance of social cohesion really tie together a lot of the kind of more technical operational challenges that we face. And I would reiterate, there's will be more opportunities, I think, to learn more lessons as we've progress in looking at more of the evidence. I would say that there's plenty of room for improvement. I think we would all agree with that. And we would be wise to cast our net widely to learn lessons far beyond our shores, including Asia Pacific countries. Thank you.
Thank you very much, Dr. Lee, Dr. Berman, Candace, and Daniela for your wonderful presentations. We have a number of questions that are coming through, and I'll offer them in just a moment. I'd like to offer or ask myself a first question, in particular, Dr. Lee, when you talked about just the importance of social cohesion, local public health responses, and all of the society approach to dealing with the pandemic and the importance of this. And now we're looking at a potential new wave of COVID coming in places like Ontario and looking in Europe and seeing increased numbers of COVID infections happening now in real time. How do we deal with COVID fatigue in this particular environment? And do we see any lessons, Daniela and Candace, for how states and economies in the Asia Pacific are dealing with this long-term pressure that COVID puts on states and societies in terms of stability, in terms of fatigue? How do we make sure that we're prepared at a time when most people are taking off their masks, even against public health guidance, that we stay vigilant for at least the short to medium terms?
Yeah, this is a huge challenge, Jeff. Thanks for that question. And I think it comes down to the communication aspects, and in some ways, it's hard to turn back the clock. Things could have been done a little differently for sure. The messaging, the consistency, the explaining to the public. There's a lot of voices and saying lots of different things. So I don't blame the public for being fatigued, confused, probably, not sure who to listen to at this point, because there's been such a cacophony of voices out there, including, so-called experts, which is what, and some of us probably needed to step back to some extent. But, maybe really it's about reinforcing the science, that to explain to the public and not to underestimate the understanding of science by the public and the desire to do the right thing. But a lot of it is about confusion and about, about really having a clear message to know what to do. So I would go back to that and simplify, and we do need to hang on a little longer. I'm afraid we're not quite out of this yet, and as much as we'd like to. So I imagine we have more chances to get this right to come.
Candace, Danielle, anything to add from the work that you've done on this great project?
I would have absolutely said what Dr. Lee said, which is that a huge part of getting the public buy-in is through communication. and communication that has been inconsistent or contradictory has really influenced the public's level of confidence. And as their confidence wanes, so does the level of cooperation and compliance that we really saw quite strongly at the beginning of the pandemic. But then, people were promised that when we got vaccines, then the pandemic would be over. And it turns out that wasn't a lie. It's just, it didn't turn out to be that kind of a virus. And so I think when scientists are expressing differences as their understanding of the virus continually evolves, sometimes that can come across to the public like they're changing their minds, or they're doing a bait and switch, or they're lying. And it's not actually about intentional dishonesty or even unintentional dishonesty. It's understanding that that's how science works. And when you're dealing with a novel pathogen, it's a continual learning process. You modify responses in accordance with every new lesson you learn. But I think if you don't communicate that then very well, it can then just look to the public like you're changing your minds for, frivolous reasons, as opposed to being really driven by the science. So that would be my main point, I think, to follow up on Dr. Lee's very good advice.
Great, Daniela or Dr. Berman? Anything to add? We can move on
The
to
same.
Okay.
Oh, hi. Yeah, just adding really quickly, like reinforcing the points of clear communication that is fact-based, and the same transparent communication, especially when it comes to the use of technology. Sometimes something like an application might be seen as imposed from the top down, and that creates a level of resistance. I think if you do efforts, like concerted efforts to respond to the feedback from people who are trying to help me, or had feedback or questions on like, well, how is this application supposed to work? For how long are you going to keep this information for? How do I know that you're going to be able to delete it? So it really comes down to building that trust and having the government become and show transparently that it is a worthy steward of that information and protector of that information. And yeah, just having clarity around those, especially if there's grievances, and being responsive to any sort of feedback, particularly if it's from like a technical aspect, constructive.
Another, well, not a related question, but something that I think we haven't really talked a lot about is we've approached a lot of our discussion in terms of national experiences and compared, I think, different policies across different jurisdictions and economies. But one of the things that the pandemic fundamentally showed us is that this is a global issue, and that while each state can approach it in a different way and have a different experience, if we really were going to try to have the best possible approach to controlling a pandemic, this would require coordination and cooperation across different economies, different states, different governments with different political types. When you look, for example, at China and its zero COVID policy, a lot of people have criticized that, but fundamentally that should have been the goal of all states, right? Is to have zero COVID. But it's an impossible situation for one state to approach that when the rest of the world is not. And now China is stuck in a very difficult paradigm of paradox of how to open up and how to re-engage with the rest of the world while maintaining its fundamental approach to zero COVID and locking down huge cities. So, I guess my fundamental question here is, how do we coordinate national responses at the global level? And how do we have the most effective means of dealing with a pandemic that ignores borders and boundaries and our own political constructs to ensure that we're working collaboratively and collectively, taking the best practices from different countries, but applying them at the global level? Because I think that the WHO has shown in many ways its deficiencies as much of it as its strengths during this pandemic. And I wonder if the experience from Asia Pacific and looking at particular about multilateralism has drawn any lessons that you might want to share with us.
Peter, do you want to jump in on this?
All right, this is more your area than mine, but I think we have to start by acknowledging that the potential for global coordination and collaboration rests on the actions of many individual nation states. So while I think one can be disappointed with some of the actions of WHO and the global processes we have, they reflect the individual countries' commitment to relinquishing some part of their own autonomy, sovereignty, to global collaboration. And that has proved to be a very difficult problem. And there are many very important conversations going on today about what to do about that problem. But my personal view is the answer to that is not, let's give WHO more money. There has to be something has to change in the understanding of that. I have to say that this is a larger case of a problem we see within countries, and we see this with large federal countries, and Canada is one of them, where there's still quite a lot of autonomy given to subnational entities, and even within states or provinces, we might even see more autonomy given to local governments, and some countries have that and have done that. That's something that's worth studying more. Okay, I'm going to stop there and let Kelly. This is really her her area of expertise, and see what she can share with us about this.
I think that's a great response. I know you're running out of time, and no, I think you're absolutely right, Peter. It's that crux between that trade-off, I guess, you have between sovereignty, state sovereignty, and the ability for collective action. I guess I would just say that we also need this conversation at the national level, but the social contract. We give up some of our freedoms, some of our rights as individuals in exchange for social goods, whether it's protections, security of some kind, and so on. And in each society, there needs to be an underpinning of a social contract. We also need a global social contract, and we haven't had that discussion, I guess. What do countries give up, but what do they get in return? I think when that balance is clearly in favor of what you get in return for giving up some of that, I'll just do what I think is right, individualism, then we're going to get some movement on this. But essentially, it's a political problem. It's not a technical problem. I think we know how to stop viruses and stop pandemics. This has been a political failure rather than a scientific one. And that's where I think we need to put all our efforts.
Candace, Danielle, anything you'd add from the work that we've done?
Yeah.
No for me. I think that Peter and Kelly summed it up really well. So I'll let Daniela chime in on the technological aspect.
Yeah. To answer that question in part is, I just wanted to plug in our fourth report on an ecosystems of approach to international engagement and global health. And we definitely, our researchers from our Engaging Asia team here at APF did a fantastic job attempting to answer that question, Jeff. And some of the key finding, like a key lesson from that is for Canada to look beyond international organizations that work at the highest level. What we saw during the pandemic was definitely some a bit of challenges in multilateralism at the highest level, like talking about the WHO or big groups like the G20, G7. However, at a more subnational level, particularly and a more regional and subnational level, particularly in the Asia Pacific, we actually saw a lot more dialogue and cooperation. So being aware of it and attempting to become a player there would go a long way into sort of fostering that internal collaboration and communication for health.
So the next question is about measuring pandemic preparedness. In particular, so Dr. Berman, this is a question that was directed to you, but I open it to all of the panelists because I think it has kind of a lot of relevance to the work that we've done focusing on the Asia Pacific. And it's how do we think about measuring pandemic preparedness going forward? And if we were so off the mark in so many ways at the beginning of this pandemic and awarded states like the United States and the United Kingdom the highest possible marks in terms of pandemic preparedness, and then saw those national economies and national states stumble so remarkably during this actual process, have we learned anything from this lesson? And in particular, to make this relevant to our discussion today, have we learned anything from the Asia Pacific economies that would help us rethink how to think about pandemic preparedness going forward and measuring the effectiveness of pandemic preparedness? And maybe a secondary question to that is, can we do that as a holistic kind of model that can be applied across different economies, or does this have to be specifically tailored for each national country, dependent on the existence of, for example, state-society relations and the nature of their social contract or the nature of the political system? Is pandemic preparedness, what I mean in China, the same as pandemic preparedness in Japan?
Well, that's a great question. I like to think we can think about this at three levels, okay? And one has to do with the stuff that we might need to be better prepared. And this is around, having reliable supply chains, stockpiles of things. And this requires allocation of resources that could be used for current needs, and really a kind of investment in being prepared for the need for stuff. And there's a national level process that has to take place. And clearly we've seen there's a global level process because low and middle income countries are much less able to put aside the resources needed for this. And probably for the foreseeable future, they are going to need some assistance in that area in terms of international development assistance, but also just some collaboration assistance. And I do think the regional opportunities, especially in the low and middle income countries, are going to be quite important going forward. It doesn't make sense for every smaller African country to have a high-level biosafety lab, but it does make sense as parts of the region to collaborate together to be able to do those things. So the stuff is one thing. The systems and the capabilities are another thing, and that's mostly what the Global Health Security Index focused on, and that's trained people, laboratories, centers for disease control, national public health institutes, and so on. And yes, that is needed, and we do see movement to strengthen those capacities right now. And again, some of the wealthier countries in the world actually had done a lot. They'd kind of lost their motivation and energy a bit in the years prior to the pandemic, because it seemed, this current pandemic, because it seemed that the threat was somehow more remote. We got that wrong. And we saw that in Canada and some of the assessment of some of the reductions in spending on these systems, but that also needs to be done. But the third aspect, which has to do with what I would call the governance and politics of making these things work, that we've really neglected. And I think we learned from the Global Health Security Index and this pandemic that getting the first level right, getting the second level right are all important, but they can be dramatically undermined. Their importance can be dramatically undermined by getting the politics and governance not so right. Now, how to do that is a very challenging question, and I don't think we know the answers to that question very well because we haven't looked at it very carefully. I do think it needs to be answered within each national context, but I do think there are some regional and global questions that we just talked about how to do that. And what we've learned really is that even high levels of what we might call technical preparedness may not be sufficient if those other things, if those governance issues are not well structured. laws and regulations and organizational structures help us solve those problems, but they need to be subscribed to by political leaders and legislatures, and then they need to be adhered to when they need to be enforced. We've seen some good examples of that happening around the world, but we've also seen some not so good examples. Thanks.
Dr. Lee?
I would just add, that's an excellent response, Peter. And I would add that under the third category, social capital, and how, just reinforcing what I said in my remarks, is that if you can have strong social capital, these are the things to draw upon when you need to roll out these sort of interventions that we've seen. And you don't have to have a high-income country, a high-income economy to create that social capital. Vietnam is a perfect example, done extremely well for most of the pandemic with very limited resources, because they've had a very good community structure, which enabled them to roll out testing very well, to use the limited resources they have in the most optimal way. So we shouldn't limit. I think Quinton in the comment questions and answers asked, why do we keep looking at certain countries and not others when we try and think about how we need to prepare? I think we have been very blinkered in the kind of role models we've tried to follow. We need to broaden that, and that is probably for historical reasons and our links to the UK and the US. But we have to look further afield, and there's so many different models out there of what we could from which we could learn. And I think from low and middle income countries to high income countries. So we need to do that. But the social side of things, I think we need to build it from the ground up. Our preparedness and engage people in this exercise.
Candace, Daniela, anything?
I'd probably just, I agree with everything that Peter and Kelly said. I'd probably just follow that up with just a little bit of an example of the importance of learning and changing and adapting based on those learnings, and not just South Korea was an excellent example. So as I pointed out in the demonstration, after SARS and MERS in particular was South Korea's real turning point. They assessed what went wrong in their response to it. And then they took steps to change, and not just at the level of technological capacity or at the level of staffing or training or whatever. They took steps to change at the structural and legal levels. They passed new laws. They elevated the authority of the KDCA. They took significant steps to fundamentally alter their pandemic response. And that's obviously not a one-size-fits-all philosophy, as Peter mentioned. Every country will have to look at that differently and decide differently what that looks at for them, but not just assessing their pandemic preparedness on, do we have enough staff or do we have enough tests? Those are really important, but the structural and institutional capacity to implement all of these plans that we have in place is really where a pandemic response begins and where it succeeds. So that's all I would add.
I'm going to jump to another and last question, because I think we have about 4 minutes left. I'm going to give you guys an easy softball one to finish up with. And not really, but actually, I think this is a difficult question to answer. As we think about, the solution to the pandemic and also partial solutions to whatever pandemic comes before us, vaccines are going to be a key role, of course, a key part of our toolkit for addressing pandemic response and recovery. We've seen in this particular outbreak, in this particular pandemic, initiatives from the developing worlds, the wealthier northern states around COVAX, for example, where a lot of promises were made early on to provide a huge amount of vaccine to the global south, to the developing world. And those promises fell short for a number of different reasons. That's led to a couple of different things. One is with respect to supply. So one question is, how do we make sure that we have equity of supply in the future around vaccines across the global south, in order to prevent things like new variants popping up in places like Africa that will ultimately come back and affect the developed economies in Europe and North America? And secondly, have we seen in the Asia Pacific any change in understanding of the leadership role of the global North and the G7 and Canada and the United States and Europe with respect to vaccines, because of the failure of COVAX to deliver what it promised, and because the Chinese government in particular stepped up with their own domestic vaccines and supplied so much to Southeast Asia in particular at a time when America and Canada and other European countries were not able to deliver those kind of promises. So it's a difficult question. Maybe pick one part of it, the supply versus the perception of the leadership role. But it's one I think is really important as we think about how to address the next pandemic.
I could start. So yes, we do need to increase capacity investment in vaccines in general. It's always an under provided public good, and it's good to have more vaccines. And initially we did have a supply issue, but we haven't had a supply issue for a long time. It's about distribution. And so, it's the basic fundamental political issue is interests blocking the sharing of these vaccines. Countries are out there ready to manufacture these vaccines and to distribute them. So it's a political problem. It's not a supply problem. And we are shooting ourselves in the foot by not sharing these vaccines. And so I think going forward, I think we're also not only in a public health sense shooting ourselves in the foot, but I think moral right to speak about global solidarity and public health is diminished if we don't put our money where our mouth is. So I think this is one of the really sore points for me, is that how poorly Canada has done, the Canadian federal government, in really allowing a waiver and then allowing these vaccines to get out where they really would impact people out there, but also ourselves. We've just really missed a trick there.
Professor Berman, anything to add?
Yeah, I would just add that I do think that we are seeing leadership in many lower and middle income countries basically recognizing that they cannot rely on the generosity of the wealthier countries in a crisis like this to respond in a time and share scarce resources in a timely way. So I think we're going to see a big movement to create more research and manufacturing capacity around the world. In a recent interview, the WHO Director General said he thought education in science and technology was the single most important challenge facing Africa. And I think that's basically what he was saying. This is going to take some time, but I think at the end we may see a more globally distributed capacity to respond. And in the interim, we may see other countries like China and India trying to at least assert themselves and say, we'll try to help you when others won't. So, thanks.
And Candice and Danielle, did we see anything like that during our research on the approach that Asia Pacific economies were taking with respect to vaccines and kind of a regionalization of vaccine supply versus globalization of vaccine supply? Did we see anything like that?
I mean, absolutely. We saw that over time in response to initially the supply issues. And then, as Kelly mentioned, not so much a supply issue, but a distribution issue. Pre-pandemic, China and India were the vaccine manufacturing hubs, but no one else in the region really manufactured at all. And biotechnology, while it was surging in areas like South Korea and Singapore, was still not really focused too much on vaccine manufacturing. However, in the wake of sort of being, for lack of a better word, let down by COVAX and the global North, we see countries like Thailand, Vietnam, openly announcing that they have developed their own vaccines. Some of them are ready to be implemented now. Some of them are still in their clinical trials, but they basically said, we're going to do our own. And I think that COVID will long-term influence their overall thinking, and that's going to be more of their attitude going forward, is that we developed some capacity during COVID. We're going to keep developing it so that we're not left getting, the pickings at the end the next time this happens. So I think it's overall, it's a positive development that is that sort of COVID has pushed these countries to develop these capacities. It's just a shame that it took this to do that. So that would be my my observations.
Danielle, anything to add?
No, not much, but yeah, like we see like developing countries definitely trying to reassert themselves more. Like more recently, like Indonesia definitely has been calling for a better distribution of vaccine production facilities, particularly for more novel technologies in vaccination, like mRNA vaccines. This is something that is very key to their agenda for their G20 presidency. So yes, like we see a lot of like trying to create their own domestic capacity, but at the same time trying to engage more strongly in existing international engagement fora to really put forth and push this agenda.
Thank you. Professor Berman, Professor Lee, thank you so much for your time today. This was a wonderful conversation, and I feel like we could continue it, but I'm very aware of the time, and I'm very thankful for the time commitment that you gave us, and sensitive to the fact that I don't want to go beyond what you've agreed to, and we've already gone about 4 minutes past. Candace, Daniela, thank you so much for the wonderful report that you put together on behalf of the foundation. Please, for those that haven't had a chance to read these reports, they're available at our website, all 4 of them. Do visit our website, and while you're there, sign up for Asia Watch. If you haven't, it's as easy as clicking an icon on our website, and you get twice a week into your inbox some of the top stories in the Asia Pacific and their relevance back to Canada. It's a great product. I do encourage those that haven't signed up to sign up. Thank you all very much today, and we look forward to engaging with you again in future events. That's all that we have today. Thank you very much.
Thank you.
Thank you.